Hey everyone, and welcome to today's webinar, Pulmonary Rehab, Helping You Breathe Easier. My name is Juliana Valencia. I am the supervisor for the Caregiver and Supportive Services Unit with Fairfax Area Agency on Aging. Before I introduce today's speaker, I will go over a few housekeeping items. Today's presentation is being recorded, and a link for the recording will be sent to all registrants a week from today. Also, there is a Q&A button where you can submit all of your questions. We are going to allocate a few minutes at the end of the presentation to address your questions. Lastly, there is going to be a brief survey as you signed out. If you could take a moment to fill out the survey, it really helps us create programs that are relevant and are important to our caregiving community. Now, it is my pleasure to introduce today's speaker, Marjorie McBurney. Marjorie McBurney is a registered respiratory therapist who has experience working with both adult and pediatric neonatal populations. She has worked as a registered respiratory therapist and COPD educator in trauma, emergency care, critical care, long-term care, skilled nursing facility care. She's done research, outpatient, pulmonary rehab, and education. She is currently the Respiratory Education Coordinator at Johns Hopkins Bayview Medical Center. She focuses on training and education in the respiratory department, as well as intradepartmental training on respiratory care service. Prior to her current position, Marjorie worked as a respiratory research therapist and senior research therapist at Johns Hopkins Bayview Medical Center, where she supported the pulmonary rehab program and worked as the primary respiratory therapist working with the Breathe 2 study, a research study focused on educating patients and caregivers diagnosed with COPD. She received her Associate of Applied Science in Respiratory Care from CCBC and Bachelor of Arts in Healthcare Administration from Ashford University. Marjorie, welcome, and thank you so much for being here. We are truly looking forward to your presentation. So I'm going to stop sharing, and I am going to let you go ahead and share with us.
Okay, thank you. Let me get my screen up. Wonderful. Thank you for having me. I'm very excited to be here. I do want to throw out a little disclaimer that I am at work despite my background. And we may hear some things called overhead. If we hear that, I'll just stop while it's being called and then we can restart into where we left off. Unfortunately, being at work, that does happen at hospitals. So thank you for the wonderful introduction. I have been a respiratory therapist for quite some time now, 20 plus years. I love my job and I love what I do. So I'm happy to speak today. So we'll get right in. I do like to start off by telling everyone that I do not have any disclosures. I do work for Johns Hopkins Hospital and I have for a long time, but there is no disclosures. So a little bit about me. I have been a therapist for 23 years, and prior to that, I worked as an equipment tech for the respiratory care department. I've been married for 21 years, and I have 2 adult children and 2 wonderful grandchildren. I love to travel, and I have 2 fur babies. So there's my fur babies. And this is my travel buddy, which is my youngest son, while we were in Scotland this year. I am lucky to have been the primary caregiver for my grandmother, my father, and now my mother, all of which have experienced chronic lung disease. I work with all patient populations, like was announced, and I have to say some of my favorite experiences have been with my long-term care patients who have lung disorders. So my pulmonary rehab patients and my research patients, I become very close to, and I do enjoy spending time and working with them. I have worked in all areas, though. Primarily in the beginning of my career in acute care, I specialized in burn and trauma medicine, later neurology and pulmonary medicine, and then went into long-term care and research and outpatient care, and now I'm in education. And I'm currently the education coordinator here. So my presentation, I'm going to define breathing and why it's so important. Discuss a little bit about pulmonary rehab and how you can sort of determine if it's right for you. It's not right for all patients. That's one thing I did learn when I went into pulmonary rehab. And then describe and demonstrate some of the techniques that are taught during pulmonary rehab that can help you just achieve activities of daily living with less shortness of breath. We'll briefly review supplemental oxygen and monitoring if you have supplemental oxygen at home, and discuss some caregiver supports. So I'd like to start off by defining breathing, because most people define it differently. So Webster's dictionary states the process of taking air into the lungs and expelling it from the lungs. To me, that seems very functional. I mean, it's very basic. Like, okay, you take air in, you take air out. So I looked a little deeper and went to my old medical dictionary from college, Egan, and it stated that breathing is vital to sustaining human life by supporting everyday functions of the body. For example, digesting your food or moving your muscles or thinking. That made a little more sense to me. So then I went a little deeper and I pulled 15 grade school students and I asked them, what does it mean to breathe effectively? Because breathing and breathing effectively are two different things. And I asked 15 respiratory therapists, what does it mean to breathe effectively? And so my grade school students told me to breathe effectively, it means when you breathe in, air goes in, and when you breathe out, air goes out. So that's very functional. It's the act of breathing. It doesn't really give me what I was looking for. So then when I asked the respiratory therapist, they stated, when you're able to take oxygen into your lungs and exhale CO2 out of your lungs, you're breathing effectively. Once again, that seemed extremely clinical to me. So I thought, what the heck? Let's ask chronic lung patients what happens when, and I think I skipped a slide. Hold on one second. I'll go back to that slide. Chronic lung patients, what it means to breathe. And they said, having enough air to do the things I need to do, like get out of bed, eat, shower, get to the car, visit a friend, all of those things without feeling like I'm going to pass out or having to take multiple breaks. And to me, that was the most real diagnosis of breathing. I mean, what do you think about when you say someone's breathing or not breathing? We think, oh, are they breathing? Are they taking air in or out? Or are they not breathing? Are they they're not doing it. But really what it means to not breathe is not being able to do things, basic things that we take for granted. I'm going to actually go back a slide. Give me a second. And it started over. I'm so sorry. Give me 1 second. Current slide. There we go. So for many patients with chronic lung disease, you can see why it becomes such a challenge to breathe. This is an example of what healthy lungs look like from a cadaver, and what a smoker's lungs look like after, and the smoker had been smoking for 15 years. That smoker smoked unfiltered cigarettes. And then healthy lungs versus mesothelioma and asbestosis in the lungs. A lot of patients, who have lung cancer, they struggle with the same situation of not being able to breathe effectively as someone who may have COPD or may have restrictive disease. So I always like to put these lungs up here because these are actually lungs of a coal miner worker. And this is what it looks like to have black lungs. And these are completely unfunctional lungs. So we know breathing is directly linked to every aspect of everyone's life. So if you breathe effectively, these things are not effective. And we kind of take it for granted because for the most part, we don't even think about our breathing. It's something that is secondary. It comes natural. It's not something we have to work at. But if you have a respiratory condition, your breathing is affected and all of these things are affected. So it's not just, oh, I can't breathe, I'm short of breath, I need to sit down and take a break. It's I can't breathe, so I can't get to the bathroom. Or I can't breathe, so I can't eat effectively. So what we do in pulmonary rehab is we teach patients techniques and we call them tricks of the trade, to allow them to be able to do things functionally that they maybe cannot do right now. But after the program, they can. The trick is to know whether it's right for you. So we're going to discuss that briefly. But you can see pictures here of me and one of my pulmonary rehab patients. When he started, he could not stand. It was too much for him. He was so short of breath, he was unable to stand. So we put him on a bike, basically called a new step, where he was completely sitting down. And he would it was almost like a rowing machine, where his arms and his legs went up and down. And when he started, he could do 3.5 minutes on that machine, and that is it. And when he graduated, he was completely off of oxygen, and he was using weights to lift weights, as well as walking on the treadmill. So what is pulmonary rehab? Well, the COPD Foundation describes it as a broad outpatient program, which includes educational classes and supervised exercise sessions that are designed to help improve the well-being of patients with lung conditions. I like to go in a little deeper on that, because it is a broad spectrum program, but it's not for everyone. It is not an inpatient program. It is outpatient, which means patients have to come to the sessions. They have to get there on their own. And it's over a period of time. It is not 1 or 2 educational sessions and then you're done. Most patients, their lung conditions were not something that happened overnight. And getting better is not going to happen overnight. Similar to exercise, if you are slightly overweight and you want to lose weight, we know we can't lose 10 pounds overnight. So you can't improve your breathing overnight. So it is actually usually a 36 session program. One of the things that patients who are referred from physicians tend to have trouble with is the fact that not everyone is eligible for pulmonary rehab. A lot of people are eligible for parts of pulmonary rehab, but they are not eligible for the full program. So I encourage everyone to discuss with their physician. First off, is it safe for you to start pulmonary rehab? It is an exercise program, so you may not be able to functionally do part of the exercise. So check with your doctor first. If they say yes and they want to refer you, the second thing you want to do is check with your insurance company to see if you're covered. We have had patients who have not done that, and when they have started in on the program, about 6 or 7 sessions in, they receive a copay bill and they realize that they can't pay for it. So if you've been diagnosed with a pulmonary disease, so COPD, ILD, IPF, emphysema, if you're a pre or post lung transplant patient, or you're post-COVID, which they like to call them long haul COVID, you could be eligible. I say could because it's based on your insurance company. And you have to have a referral from a physician to get in. It cannot be a nurse practitioner. It cannot be a physician's assistant. it has to be an MD or a DO that refers you to the program. Next, does your insurance company cover it? So I can tell you that recently there have been a lot of discussions in the back end based off of some Medicare standards. Up until recently, Medicare only covered pulmonary rehab for COPD patients who are considered moderate to severe stage COPD. Now they're actually covering pulmonary rehab for the long haul COVID patients as well. But they do not cover pulmonary rehab for any other diagnosis on Medicare. We are fighting for that to be changed because we have seen patients who have come through the program with a restrictive disease or ILD or IPF, asthma, who have done very well, and it has helped them. But at this time, Medicare will not pay for it. If you have a private insurance, then that's different. Each insurance company is a little different, so that you would have to be clear. You have to clarify that with the insurance company, and we do get you approved prior to you starting through the program that I've worked with. We have someone who approves you in the back end, but you may have a copay, and some of the copays could be up to $30 or $40 a visit. So for 36 visits, that is pretty expensive. And then finally, are you ready? So I like to ask all the patients when I call them if they're ready. We will determine on the back end before we even call you if you have all the needed tests. So you'll have to get a PFT, which is a pulmonary function test, and it will have to be pre and post bronchodilator. You'll have to get blood work. It's pretty basic. If you've had blood work within a year, it's the same type of blood work that you would get on a routine doctor's visit. You'll have to have a chest x-ray or a CT scan within a year, and you'll have to have an EKG within a year. If you've had any hospitalization within the year that is for a cardiac reason, you'll have to have an EKG within 6 months of starting the program. And then, do you have the ability to attend this program? Because it is 36 visits. Sometimes we will, like if a patient's doing really well and we know they're going to be able to maintain at home, we will cut it back to 24, 26. But for the most part, 36 visits is what's needed to get everything in that we need to review with you and for patients to start seeing the difference. So if you cannot make that attendance, you will be dropped from the program. So it's a lot of work for you to start over. So if you're not going to start in the program, it doesn't make sense for you to even start the process if you can't make it. And then finally, are you willing to make changes? A lot of our patients, they'll say, yes, I want to make a change. And when we start talking about, okay, so the first change you have to make is you have to stop smoking because we can't allow you to be an active smoker in the program. You have to, take the steps to try to quit. They'll say, but I don't want to quit. So you're not ready to make that change, which is fine. I understand it's hard. It's hard to quit smoking. It's hard to do a lot of the stuff that we have to do to stay in the program. So why don't you give us a call when you're ready? Or the patient will say, well, I want to do this, but I can only come 1 day a week. Well, we need you here a minimum of 2 days a week to really get any benefit out of the program. So if you can't make 2 days a week, then maybe this isn't the best time for you to start the program. Maybe you need to wait until it is a good time. So what does the program include? It includes a lot of education on your condition, your medications. Oxygen therapy is considered a medication. So we kind of loop that back into medications. Recognizing and avoiding triggers, because the number one issue that patients have with their lung disease is that something triggers an exacerbation. So instruction and practice on the breathing techniques are a big part. We start with that and we literally utilize it throughout the entire program. And then nutritional counseling, we offer nutritional counseling, whether you are trying to lose weight or gain weight. We offer both. We actually have a dietitian who works with the programs. Emotional health and support, because believe it or not, 2/3 of our patients who come into the program have severe anxiety and or depression symptoms because of the fact that it's scary when you can't breathe. And if it goes on for a long time, you get conditioned to panic when something happens. And then just teaching ways to reduce exacerbations and to become more active through supervised education and exercise instruction. So educational and resources, we try to keep it specific to the condition, because having a restrictive lung disease versus an obstructive lung disease requires different education. But 2/3 of our patients are COPDers. So we will look at your condition, we will talk to you and see what you are looking at. As far as I've had patients who just want to be able to get to the bathroom and bathe themselves without help. And then I've had patients who want to get on an airplane and go to Hawaii because that's on their bucket list and that's what they want to do. And then medications, we review all of your medications with you. We also stay in contact with your doctor in case medications need to be changed or are changed through your doctor, so we can be sure to assess your plan, your treatment plan. If you all of a sudden go on a blood pressure medication and we bring you in and put you on a treadmill, we want to make sure that you're not going to pass out when you're on it. And then we discuss specific triggers to your condition. Some patients, weather changes are very difficult for them, especially COPDers and asthmatics. And then we have patients who have triggers that are internalized, like emotional triggers. Panic, the feeling of panic can cause someone to become very short of breath very easily. Allergies, pain, and obviously a lot of us saw with the COVID and the RSV outbreaks that happened, illness can cause a lot of issues with anyone with a respiratory or lung condition. We provide the nutritional support and counseling. A lot of this goes hand in hand with the comorbidities that patients have when they have lung conditions. So diabetes is a huge comorbidity for a lot of our patients, as well as congestive heart failure. So we look at low sodium, low sugar diets, and then also food allergies. Some patients, one of their triggers is food allergies. I've had a patient who did not realize she had a lactose intolerance. And then every time she would drink milk, she could not breathe. Finally, the emotional support. We do have counselors who come in and run mini sessions with groups of patients. We have grief counselors, but we also can get you in touch or work with your provider if we notice that there is a change in your emotional support and your mental health while you're in the program. We've had patients who come into the program who say, you're the first person who's asked me about this, and yes, I am having issues. Is there any support? And then we'll work with the doctor to get you additional support as well. The most important part, I feel, of pulmonary rehab is allowing patients to safely become more active. I've had patients who walked into the first class and have said, I cannot exercise, I cannot get on that machine, I cannot do this. And by the end of the session, they are helping other patients with setting their machines. So the most important thing is it is supervised. A lot of times it's one-on-one or 1-to-2 with these patients, with a patient. So you will be there and I will be working with you. You saw that in the pictures specifically. Towards the end of the program, you might be like, I don't need your help anymore, which is what we want because we want you to continue it at home. But the whole point is to make you stronger and have you become more active in your daily cares and in your daily life. Whether your goal is to bathe yourself or your goal is to play with your grandkids or your goal is to walk, your dog, whatever your goal will be. And through all that, we are teaching you breathing techniques to help with your condition. So I like to do a quick tutorial here. Breathing, the most important breathing technique that we use is pursed lip breathing. You might hear someone call it diaphragmatic breathing, but I feel like that's an older term, or it's just the term that's used in a hospital more than anywhere. But pursed lip breathing is the number one, technique we teach our patients. You can use it anytime. I call it smell the roses and blow out the candles. So what you're going to do is you want to be comfortable. You want your feet flat on the floor. You want to be sitting in a chair that supports your back to learn how to do this. And then you're going to take a slow, deep breath in and try to relax your muscles up in your neck and your shoulder area. You're going to take a slow, deep breath in through your nose. Then you're going to hold it and you're going to count to 3. And then you're going to blow out, and you're going to try to blow out for twice as long as you inhale in. So let me demonstrate really quick. So you're going to relax, and then you're going to breathe in. So when you breathe in, you're going to count to 3. Breathe out, try to count to 6. So 1, 2, 3, start. And that's going to help you, number 1, to catch your breath. Number 2, to do things while you maintain your breathing. So if you're picking things up or say you're leaning over to grab something or you're stepping up on a step, you want to make sure that when you're exerting yourself, you're blowing out all that air so that you can exhale all that CO2. So you're not short of breath on the next breath. There is, and I believe they're going to forward these slides to everyone, but there is a website here, a YouTube link that you can click on, and it demonstrates it as well. Huff coughing is another breathing technique. This is big for anyone who has a lot of congestion that they find, especially in the mornings or at various times during the day, as well as patients who have different conditions like bronchiectasis that have a buildup within their lungs and their airways of mucus. So you want to make sure you're also sitting for this technique. And that you're in a position that allows you to support your back. You want your feet on the floor. And then you're going to do pursed lip breathing. So going back to the previous technique I just taught, you're going to do that type of breathing for 3 consecutive breaths. And then after your 3rd breath of rhythmic breathing, you're going to try to hold your breath for 2 to 3 seconds after you breathe in. And then you're going to attempt to exhale with forcing that air out, not the relaxed breathing I just did, but forcing that air out. A lot of times I'll teach patients to put their hand on their belly or their abdomen and their hand on their chest. And you're going to want to use your abdominal muscles to push that air out and say "foo" at the same time. It sounds a little crazy, but I'll demonstrate it. So you're going to do 3 pursed lip breathing techniques. And on the 3rd one, you're going to force that air out. So So that's huff coughing. Now you want to wait before you do another, excuse me, it did what it did and what it needed to do. It mobilizes any kind of congestion you may have in your airways. But you want to wait and do it multiple times, 3 or 4 times. If you feel like you still have a lot of congestion in there after the second time and you're doing long exhalations at the end with that poo, you want to do a short exhalation after that. Because maybe all of the congestion is sitting in your small airway, then you need to do a shorter exhalation to mobilize it. But that's huff coughing. Hand on the belly, hand on the chest, those good deep breaths with your pursed lip breathing, and at the end, the forceful exhalation saying boo. Energy conservation, we teach energy conservation throughout the program. It is not through BG&E or Constellation or any one of your energy companies. It is strictly your body's energy. And it's how to conserve that energy while doing activities. So I don't know about anybody else, but I tend to try to group activities together. So I'm doing 3 or 4 things at one time. And unfortunately, when you are short of breath or you do a lot of coughing, that takes up a ton of your body's energy. It can leave you feeling really weak and very tired. And learning how to do things with the energy conservation techniques will help you to do more of what you want to do, maybe not all of what you want to do, but more of what you want to do with less shortness of breath. So in energy conservation, we teach what we call the 6 Ps: prioritize, planning, pacing, positioning, pursed lip breathing, which we already learned, and positive attitude. And as you can see in my little energy saving conference here, everybody's taking a nap. Went too far. But so with those specific principles, let me go back. Jump in, there we go. With those specific principles, prioritize what you need to do. If you need to get up, get dressed, eat breakfast, and be ready for an appointment. You know that you tend to get really short of breath when you get dressed. And then it makes it very difficult to eat. So maybe you should get up half an hour early and get dressed and take a break. Sit down, do some pursed lip breathing, have your clothes ready so that you don't have to walk across the room, get your clothes and walk back to get dressed. Have them ready there. And then you can go in and eat breakfast. Maybe eating breakfast, like when you go to cook, it's very difficult for you. You get very short of breath because you have to stand. So let's pull a chair over. And while you're prepping your breakfast, you can sit until you're ready to cook it. And then you can eat, and that's all you're concentrating on when you're eating. From there, you can put everything in the dishwasher, but don't worry about, doing the dishes right now. That's not something you need to prioritize. And then get yourself ready to leave. So you'll plan ahead to have everything ready. You'll prioritize the things that need to be done. While you're doing those things, don't worry about the other things. Just do those specific things. Pace yourself. If you need to sit down and you need to take a break, do so. Use your pursed lip breathing to get through the activity. And I find a positive attitude. Yes, you're short of breath, but you know what? You're doing what you can in the time that you can do it in, and you're taking your time, and you're going to get this done. You'll find that all of these things will help you in the end to get to your end goal. Supplemental oxygen. I couldn't tell you the number of patients who come through pulmonary rehab who can't understand why they are short of breath, but their doctor will not give them supplemental oxygen. Basically, you have to qualify for supplemental oxygen because it is a drug. So I always say, if you're not in pain or you don't have a headache, you're not going to take a Tylenol. So supplemental oxygen doesn't treat shortness of breath. Supplemental oxygen treats someone who has a low saturation of oxygen in their blood. You can feel short of breath and still have a perfectly acceptable oxygen content in your blood. So unfortunately, you do not qualify for supplemental oxygen if your oxygen level in your blood is not less than 88%. So if you do qualify for oxygen, I have patients who say, I have this heavy tank that I can't lift. What, can I get something better? Can I get something easier to use? That is actually strictly based on what your needs for oxygen are. Because if you only need 2 liters of nasal cannula, then it's easier to get a smaller tank, or it's easier to get a portable concentrator that will give you what you need and meet your needs. However, if you are on 6 liters of nasal cannula, and that's what you need to functionally get the oxygen saturation above 88%, then the other devices that I just mentioned, they're not going to work for you. You are going to need that large tank like here to give you that amount of oxygen and be able to go to a doctor's appointment. Because a small one like this is only going to last you about 45 minutes. But a large tank like this will last you 3 hours. Finally, I have had several patients lately who have stated that they went home on oxygen and no one basically taught them anything. The tech came, dropped the oxygen off at their house and left, and they didn't receive any education on it. So they were still cooking on a gas stove with their oxygen on. Under no circumstances should anyone have supplemental oxygen near a lit flame, whether it be a stove, a candle, or if they're still smoking. It sounds kind of silly that, why would someone still smoke if they're on oxygen? But we have a great number of patients who do smoke and are also on oxygen. And that is the easiest way to give yourself an inhalation burn. So we encourage patients' family members to participate in pulmonary rehab with them. I find that patients who have at least one or more caregiver who participates in the program with them, meaning they bring them, they watch what we do, they learn the pursed lip breathing techniques, because if you are really short of breath and you are panicking, literally having someone sit down in front of you and do the pursed lip breathing with you helps immensely. So this is one of the steps we call them our step stools that we give to the patients and the families and the caregivers. And it doesn't necessarily have to be a family member. We've had patients who have friends who come with them to help learn this stuff. So we go over recognizing the extent of the limitations that the disease is putting on the patient, because a lot of times we'll see friends and family members say, oh, but I'll come get you and bring you, to this event. You can be in the wheelchair, we'll push you so you don't have to walk, which is great. But then the patient gets there, they're with their family, and their family is doing other things, and they can't do those things with those family members. So they feel alone and separated from the family, even though they're there at the event, they can't participate. And then encouraging the lifestyle changes that someone has to make because they have, lung disease. Encourage them to embrace the things that they can do and to participate in those things with those patients. Attend appointments, obviously, not just pulmonary rehab appointments, but attend appointments with doctors with these patients. so that you can hear, if their condition is progressing or they're getting any better or what needs to be done to help support. We review the medications and the use of oxygen and the sequence of medications with all of these patients' family members, as long as the patient agrees to allow us to do so. And then to learn how to recognize the symptoms, because sometimes the patients don't initially recognize the symptoms, family members recognize it first. If a patient's CO2 is slowly climbing, that's something that the patient doesn't necessarily recognize, but the family member does because they're starting to get confused. And then how to initiate treatment and escalate the care for that patient. Many times it's the family member who says, I'm calling 911. The patient doesn't recognize that there's something wrong with them, but the family member does. Education on any comorbidities that, the individual might have. Diabetes is a big one. I've had patients whose family is, they're making them dinners and putting it in the fridge so the patient doesn't have to cook, which is great, but they're making them a lot of pasta dishes because it's easy to store them. It has a lot of carbs in it, which COPDers tend to do better with carbs, but if they're diabetic, that affects their diabetes. So we review all of those types of, things with the comorbidities, or if a patient is a COPD but also has congestive heart failure, and they start sounding like they're wheezing, but you give a nebulizer treatment to help with the wheeze, but it doesn't go away. Maybe it's fluid on board and not a true bronchoconstriction, and how to treat that and how to, get treatment for that. And then finally, we just educate in general about the breathing disorders. There's very different, there's a lot of differences between an obstructive and a restrictive disease and how we treat it. And post-COVID lung conditions actually are falling into both obstructive and restrictive based on what happened to the patient while they had COVID. So I like to summarize by saying that pulmonary rehab and the education can help someone diagnosed with lung conditions live their lives one breath at a time. It's really important to know that you don't have to do everything all at once. And that with any kind of rehab, especially the breathing techniques, you can learn how to do things, maybe not at the pace you want to do them, but you can still accomplish them. And this is a picture of my mom, who I am actively caring for right now, with one of my fur babies, Muppet. My mom is a very end stage COPDer. She is on 8 liters of high flow oxygen at home. And she also has several other comorbidities, unfortunately, that contribute to her breathing. And you can see her little nebulizer machine here in the back. But she did participate in pulmonary rehab at one point, is not functionally capable of doing it right now. But she has been diagnosed with COPD for almost 22 years now. And that's it. These are all my resources.
Thank you so much, Marjorie. That was such a helpful and very informative presentation. At this point, I would like to invite our audience to submit their questions to our presenter. You can use that Q&A button that we have. So if you have any situations or any concerns, please, we would love to have a conversation with our speaker about that. In the meantime, I do have a couple of questions for you. One of them, you kind of went over that, but I would like you to expand a little bit if you can. Are there any risks associated with pulmonary rehab, especially for an older adult? You did talk a little bit about the aging and fragility of the person. Could you expand a little bit more?
Sure. So we've had patients who are 96, 97, 98 years old come through our program. here. And I know of other programs that I've worked very closely with who have had older patients come through as well. And I think our biggest concern, and we do work with the patient, we've had some patients who did not have the stability with walking, they walk with a cane, to walk on the treadmill, but that's perfectly fine. We walk them on a flat surface. We walk with them to make sure that they are stable and they're steady. And we put them on other machines. So we have the New Step. The New Step is a wonderful machine. You are actually sitting back and you move your arms and your legs in a rowing kind of fashion, but it's much easier to do, and it literally works every muscle group in your body. We have had patients who were double amputees, so they can't walk at all. And as long as they're able to exercise their arms, we have weights, we have an arm ergometer, we have other, stretch bands that we work with patients with exercise wise. We do require patients to be cognitive. So obviously if a patient has a dementia diagnosis and they are not able to participate because of that, we can't accept them into the program. We also, we don't allow them to use medications that will alter their conditions. So if you come in and you are suspected to be under the influence, we do ask you to leave. If it happens more than once, then we will remove you from the program.
That makes sense. So you are with Johns Hopkins. Do you know if these programs are also offered through other hospitals in Virginia, specifically in our area, Northern Virginia?
So yes, there are quite a few. I can actually get you a list if you would like, and you can forward that to the, the participants today and anyone who's here, the audience. I know that Howard County offers, in Maryland, offers programs. But yes, I can get you all of the, I know DC offers quite a few as well. Simply, primarily, I know they do offer. But I can get you the whole list.
Great, thank you. Yes, that was one of the questions from the audience. I will make sure to forward that information once you send it over to us. So somebody else has sent a question, and it says, how is effectiveness of pulmonary rehab process with patients with post-COVID breathing symptoms kicking up childhood asthma breathing issues? It's quite a question.
Yes. So I'm trying to, let's see. So our program doesn't work with children at all. We are strictly an adult program. Usually for pediatric patients, their pulmonary rehab programs are pediatric specific, and would have to go through, I know Mount Washington offers one. However, for adult patients who've had childhood asthma, who also have had COVID, what we found with those patients, a lot of those patients are they're the ones that are hitting in the long haul COVID range. They already had a condition. They may have had a condition as a child and it's gotten better as an adult, and then they got COVID and it flared. I always like to tell everyone, if you have asthma, even if it's as a child, you don't grow out of that condition. It's just, you may not have as many triggers as you get older because our body always changes. You don't grow out of the condition. It's still there. You still have the capability of finding that one trigger that will cause bronchoconstriction and cause you to go into an asthmatic flare. So I always encourage my patients, even if they say, well, I had it when I was younger, but I don't need my inhaler anymore, to keep an inhaler on them.
That's good to know.
A lot of our long haulers had either bronchitis as children, any kind of comorbidity as a child with breathing. They've had multiple bouts of pneumonia when they were a kid and they grew out of it. And now, unfortunately, because of COVID, they're struggling.
And you said that was part of the eligibility criteria now, because of kind of only the COPDs makes it or people, somebody who with COPD will be eligible. Is that right?
Right. Yes.
Okay. So the next question that we have from the audience says, what tips do you have for a home health aide who comes into the home to assist clients with pulmonary issues and you see a decline? I have issue with clients waiting too long to go be seen. Do you have any language that may help? Or I would say, and then this can be very stressful for them. I guess programs in other languages, right? Maybe.
Right. So we see international patients through our program. And we have interpreters who come in who work with us. We also have the ability to give handouts in various different languages. I think right now we have the ability for 26 different languages. For home health aides who are going in and seeing this change, I know a lot of times what I've seen is the patient doesn't want to go to the hospital. That's their biggest fear. I don't want to go to the hospital. And they will wait until the last minute to call for help. The problem is that those patients come in, and those are the patients we end up putting in the hospital on a higher level of care. So either a BiPAP or a non-invasive ventilator, or having to intubate them and put them on a ventilator. And the worst thing we could do to a COPDer is intubate them. It's so hard to get them off of a machine once they've gone on. So I always encourage patients, and I tell them, like in our first visit, if you are really not feeling well, call your primary care physician at the first sign of a symptom. So let's say you're coughing and you're bringing up more mucus, and now it's kind of yellowish. Call your provider, because they can give you an antibiotic now over the phone. You can have it delivered to your house if you need to, and you can start it immediately. And if you don't feel better within 2 to 3 days, that's when you escalate care, and you may have to go to I don't know if you guys have like the outpatient emergency centers there. We have them here in Maryland, or the emergency room. But if you catch it early on, a lot of times you can do what needs to be done and never have to go to the hospital. You can follow up with your pulmonologist or your primary care physician. And if you do have a pulmonologist, or let's say you don't, you use your primary care physician for everything. Establish a good rapport with that doctor, because they're going to be your direct link to keep you out of the hospital. You come into the hospital when you need to, but you don't want to be here unless you absolutely have to. And waiting till the last minute, you're going to stay longer. If you wait until the last minute, you're looking at least a week to 10 day stay in a hospital with COPD. If you catch it ahead of time, you won't have to come to the hospital.
Oh, that's really good to know. And especially for families, as you mentioned, they might notice that before the person does. So that's very important to know. And just a quick reminder, you said that the person really or the first professional who really needs to assess whether you are an appropriate candidate for pulmonary rehab will have to be your primary care doctor. Is that right?
Or your pulmonologist. It has to be a doctor, though. It cannot be. So, for instance, I know my mother, her primary care is actually a nurse practitioner. So when we got her, wanted to get her into pulmonary rehab, we had to go through her pulmonologist, because the nurse practitioner could not order it. Medicare wouldn't allow it. They'll actually deny it. They'll deny the approval for it. So we had to go through the pulmonologist to get it cleared so that she could get into the program.
Okay. And let me ask you this, because I would imagine that it's going to be very hard for everyone to qualify, even if they, if they wanted to do it. Are there classes or clubs or places where people can go and learn some breathing techniques that can help them manage some of the conditions they have?
So I'm not sure about Virginia. I don't have to look into it. But I know there are better breather clubs.
Yes.
that have been established in various different areas. In fact, I'm planning to give a presentation on long haul COVID to one of the Better Breather clubs that popped up for the post-COVID patients. And that's in May. But there are a lot of Better Breather clubs. Most of them are dedicated, unfortunately, to COPD and the obstructive diseases because we see more of that. Although in my area, there's a lot of sarcoidosis patients that are seen here, and also ILD patients. It seems to be like we've had almost like a boom in these type of patients that have that condition. And it, but prior to that, we primarily saw COPDers, bronchitis patients, asthma patients, those type of patients. The Better Breather clubs are geared towards those patients. Unfortunately, the restrictive patients, there's very few, I call them peer support groups or educational support groups for those patients. So we do try to get them into rehab as quickly as possible when they come through, because they just don't have the support that the others do.
Mm-hmm. Okay, thank you. Then we have another question from the audience. It says, walking causes shortness of breath. Should I be using that pursed lip technique when walking or even taking a shower?
So yeah, we teach you to use that while you are doing everyday activities. So for instance, if you're going up the stairs, we actually have a set of stairs that we have patients walk up and down. And we have them do the pursed lip breathing while they're doing it. So what you want to do is take that deep breath in and then blow out as you're stepping up the stairs. Some of our patients can only make it up one stair at a time. Some patients can go up two and then they stop because they're out of air to blow out. And then they'll take a minute, they'll take a couple of deep breaths, the pursed lip breathing, and then they'll do it again and they'll go up. So they'll take that air in, they'll step up and breathe out at the same time. Then they'll stop. Once you get to the end of that breath, stop your walking. And if you need to take a minute or a few seconds to catch your breath, you can, and then go up again. Pretty much anything for someone, especially if they're moderate to end stage lung condition, can cause shortness of breath. Even coughing, sneezing can cause them to be very short of breath. Taking their shirt off, lifting their hands up and holding them if they have to, can cause shortness of breath. So we teach them when you're exerting yourself, especially, that's when you want to be breathing out. So you'll take that deep breath in whatever activity, whatever exertion you're doing during that activity, you'll do what you can on that breath and then you'll stop. And then you'll take another deep breath in.
Oh, wonderful. Those are really wonderful tips. Thank you. And we are actually getting some comments from the audience as well, that this session has been very informative and wonderful information. Thank you. My last question, it has to do with how often or how many times can a patient attend a pulmonary rehab program?
So if you're private insurance, each one is different. I know some of them, they don't have a maximum requirement. Most insurance companies follow Medicare standards now, unfortunately. And that is a maximum of 72 sessions in a lifetime. So if you're doing the 36 sessions, that's 2 separate times in your lifetime you can do pulmonary rehab. So a lot of patients do wait. They wait until they are at that moderate to severe stage before they come through. However, we've had some patients who start earlier and then they actually utilize that in, as they are progressing with their disease process. But I highly encourage you, if you do pulmonary rehab, to take everything with you and utilize it outside of the session. That's how you're going to be, it's going to be the most effective for you. So, once you get to the point where you can walk safely and you know how to monitor yourself, like, how you feel and what to look for if you're getting too short of breath, to stop and to breathe, do it outside. even if it's just up and down your driveway. You know, do it in your house, even if I had one lady who lived in a condo residence and she made a loop of her condo, you know, outside in the hallway. And that's how she walked.
Yeah, small steps, right? It's very
Yep.
helpful. Yeah. Well, we are at the end of this program, and it has been very, very informative. Thank you so much for providing such wonderful information. We really appreciate it. And thank you for being here with us today. So, and for answering all of our questions. I think there might be a last question. Actually, it's a comment from the audience. It says, excellent presentation with lots of helpful information. Yes, we thank you for being here. And I also want to thank everyone in the audience for being with us today. We really appreciate you, and we want to continue to provide programs that are important to you. So if you take a moment, if you could take a moment to fill out our survey and let us know what you thought of today's presentation. And if there are any comments that you want to send to our speakers as well, please put them in the survey. We'd love to hear what you thought. I also want to invite you to our next health and wellness workshop on maintaining balance as a caregiver with mindfulness and self-compassion. Now, this workshop is going to be held on Friday, April 7, and our facilitator is going to be Alfred Wishart, who is a licensed professional counselor. He's also a licensed chemical dependency counselor. He's a certified rehabilitation counselor, and he is certified teacher in mindfulness-based stress reduction and trained in mindful self-compassion. So thank you so much to everyone. Thank you, Marjorie, and have a good afternoon, everyone.
We'll do the same.
Thank you. Bye.